Hi, everyone. I'm Sanjoy Dutta, Vice President of Research at JDRF. I am delighted to be able to give you an overview of our research strategy and some of our priorities, and most importantly, some of the recent successes in each of the areas. So what I'll walk you through is how do we define cures and what are the priorities within the cures? What are those projects there? Then I'll speak also about improving lives, which remains to be important as well in the research strategy. And then give you some recent news in the type 1 diabetes field that's super exciting, at least a select few of them here. So this slide will not be new to any of you. Our vision has always been a world without type 1 diabetes, and our mission has always been to try and find life-changing breakthroughs that cure, prevent, and treat type 1 diabetes and its complications. So in all the 50 years that have been in existence, we've been laser focused on our mission, and we continue to deliver and hope to get the cures soon to people with type 1 diabetes. In the research department, as well as with our collaborations through other departments such as policy and community engagement, one of the critical ways we look at it is how are we working the pipeline? And I'm delighted to say at least two things here. One is these chevrons indicate key inflection points as an idea goes into research in a lab and then ultimately goes into the hands of people with diabetes. And the first point is that the only metric we judge ourselves with, whether we're successful or not, is are people with diabetes doing better? For that, each of these chevrons have multiple steps and stages inside of each of these, but it basically goes from laboratory science into animal testing and then into human clinical testing with translational research. And then it goes through the critical step of regulatory approval for the safe and effective use of the therapies. And then a critical piece is there access for those therapies? And the buck doesn't stop there. Even when a therapy is approved and accessible or is covered by payers, there is sometimes inertia at the level of a clinician to prescribe it, at the level of a person with diabetes to use it and to continue to use it. And so there is a huge effort we have in clinical adoption as well. For today's RIV call, I will focus primarily on the left two chevrons here, which is led by the research department. And then we partner with several others as you move to the right. And so the second point I'd like to make on this particular slide, and I'm very proud of being part of the JDRF staff here, is that we have internal bench strength at each of these chevrons here. And while we work with external collaborators and experts and companies and foundations, we do have the internal bench strength to judge the best research that we can fund to make progress on our mission. Let me walk you through some details of our research strategy. So in a nutshell, our goal is to prioritize research funding that has the highest likelihood of accelerating the delivery of these therapies to people with type 1 diabetes that can cure T1D, while we will continue to maintain a strategic gap-filling research in the improving lives category here. When we say highest likelihood, it's because we want to ensure the best use of our resources here and bet on the ones that will likely get to people with diabetes faster and better. When we look at the research program and the research department, the way we organize ourselves is almost along the disease continuum. If you allow me to walk you through this, if you go from left to right on the top row there, the core programs we focus on are cures and improving lives, as I mentioned at the beginning of this call. The projects in the middle row there are based on kind of a disease continuum. First, you need to know who is at risk of developing type 1 diabetes. And I'll get into the details in the next few slides. And so screening is a critical project there. Once you identify these people, you want to ideally slow down the disease, stop the disease, or cure, reverse the disease. And so disease-modifying therapies, which again, I'll get into in a second, is the second project. The third project is another alternative strategy of getting at cures, i.e. through cell therapy, mainly through beta cell therapy. And then in improving lives, it covers a whole gamut of treatments available, both for glucose control, metabolic control, as well as for preventing short-term and long-term complications, including mental burden and improving mental health. And then a critical piece that we pride ourselves in is training of the people that remain in diabetes research and the clinicians. So the middle panel shows you a pipeline of therapies we are trying to develop. The lower row there is the critical piece of continuing to innovate as well as have the people pipeline ready. Have the researchers engaged in type 1 diabetes, have clinicians, preferably endocrinologists engaged here, and therefore our training program is a critical piece that we prioritize each year. Getting into a little more details of what was shown in the previous slide here, again, if you go from left to right in the top panel is, we ideally want to have a global universal screening program. We want to have multiple disease-modifying therapies and beta cell therapies developed. We are not losing sight of the fact that improving the lives of people today with type 1 diabetes is critical and preventing them from getting the daily psychosocial burden of living with the disease, as well as the long-term complications of organ function loss, such as vision and other things. And I mentioned about the training piece already. Let me get into each of the projects within Cures first, and then I'll get into improving lives. So screening for risk of type 1 diabetes. What do we have today? And you'll see this resonating theme in each of the project areas. What is the reality of today and what is the vision of the future? Today, we do have several screening programs that I'll show you in the next slide here, but it's mostly familial screening. We do have some general population screening. Currently, with all our screening efforts, it captures about 10% of the people who are getting screened. So we are not screening 90% of the people that need to be screened. Screening has proven today that it reduces DKA, a dangerous condition that often leads to hospitalization and sometimes even leads to death. The DKA rates have gone down from 40, 50% in some geographies, 60%, all the way down to 5 to 1%. So just by screening, even in the absence of disease-modifying therapies, we do have a benefit there. And there are other benefits of screening. Where we want to be in the future, where we're looking ahead 5 years, 10 years from now, is we want to be able to screen as many people as we can. We want this to be adopted by the healthcare system and do that globally, because we are a global organization, and ideally accelerate the development of these therapies so that we can have them in the hands of people with diabetes soon. So the additional benefits of screening are, just by screening, there's improved diabetes care, there's awareness, there is education here, and it improves long-term outcomes such as hemoglobin A1C. It also identifies more people at risk, as I highlighted in the previous slide, and that makes them available for clinical trials if they're willing and able to. And that accelerates the development of newer therapies and better therapies, whether they for curing the disease here. And as I said, there's a pressing need and urgency to expand our screening at the moment, and that's what we'll be focusing on in the next few months. Current efforts, and this is just 4 examples of the key efforts we have. There are other efforts that I didn't put in the slide just in the interest of time here. This shows 2 main points. One is we have multiple screening efforts ongoing to identify people at risk, and mostly these are family members of people that already have type 1 diabetes. But the second point is it's already in different parts of the world. TrialNet is mostly US-centric. It also has some sites outside of the United States. TEDdy is an international consortium for risk. FRIDA is mostly located in Germany. And ASK on the top right is based out of Denver, based out of Colorado. And so we do have other efforts ongoing. So we are trying to expand the screening to cover more people that are at risk, to identify them and make these therapies available to them by accelerating clinical trials. So screening will remain a priority. Why screen? Because we want to test disease-modifying therapy. So that brings us to the next project within Cures. Again, the same theme here. What is the reality today and where do we see the future being? Today, we have several promising disease-modifying therapies that have shown the ability to delay the onset of type 1 diabetes and in many cases preserve the beta cell function, the critical insulin-producing cells in the bodies. However, they're either in clinical trials or they've just completed clinical trials. And there are several other therapies that we have discovered in animal models that can regenerate, regrow the beta cells, as well as other therapies, immune-based therapies that can slow the progression of the disease. Where we want to be is have many options for people, have these commercially available to be prescribed and to be utilized for people with diabetes or at risk of developing the diabetes so that we can delay the progression of the disease, halt the progression of the disease, or ideally reverse the progression of the disease, or offer the cures, which is our mission at JDRF. And to cure the disease, we have to get to the bottom of the problem. There are two essential challenges in an autoimmune disease like type 1 diabetes. First, it's an autoimmune disease. So you have an active immune system. And it's called auto because it destroys your own cells. The cells they target are the only cells that produce insulin, i.e. the beta cells. So to cure type 1 diabetes, we believe that we have to have both, we have to modify the immune system as well as regrow the lost beta cells. And our role is to accelerate the development of these therapies that can do both. And they can be deployed either individually or in combination. So these are some recent breakthroughs, and I think you've heard about them before, but it's good to take a look back and see how we came to where we are. So on the left here is a drug called teplizumab, which is an immunotherapy that targets one particular immune cell in the body here. Years of research funded by JDRF, as well as the TrialNet, which is funded by the Special Diabetes Program, demonstrated that teplizumab delays the disease onset by now up to 3 years, which is significant. And it's also being followed, these people are being followed further here. The JDRF T1D fund acquired rights to this particular drug, and they are partnering with Prevention Bio right now, and it's currently being reviewed by the FDA for what we call stage 2 diabetes. These are people that are at risk of developing the disease and becoming insulin dependent, and can we prevent that from happening? There are many other therapies in development, but I don't have time to get into all of those. To the right is a particular drug. It's an old drug that we have presented before here. It's a blood pressure lowering drug approved for kids as low as 7, 8 years of age. So it's very safe and effective. Through a lot of basic research funded by JDRF, we found that this particular drug is able to preserve the critical beta cells that produce insulin in a person that was just diagnosed with type 1 diabetes. What we're focusing on now is not only identifying new therapies that can regrow the beta cells, but how can we expand the effects of this drug, verapamil, into bigger, larger clinical studies, into younger population. And so we have efforts ongoing that we will be able to report back in a year or 2 years' time here. So it's actually very exciting times. We are now at the precipice of seeing disease-modifying therapies show their effect in human clinical testing, and being very safe and effective. We hope that there'll be approved therapies in the market soon so people can benefit from this. Let's go to another form of providing cures to people with type 1 diabetes. This is actually a very unique approach. It's based on the only available cure today, i.e. islet transplantation. This is from donor islets, the donor pancreata from people that have passed away. So what has been demonstrated for more than a decade, close to 2 decades now, is people that receive transplantation actually live insulin independent, better lives, much reduced hypoglycemia, and other long-term benefits for up to 15 years. But it does come with some challenges. One challenge is these people have to be on chronic, lifelong immunosuppression because you're receiving cells from a foreign source, from another person here. And the second thing is there's always this supply-demand challenge here. The demand is way too high for people that need these cells, and the supply is very limited. Research that we have funded over the last 10 years, and others have funded as well, has now shown us that we can make these insulin-producing cells outside the body and put them back in the body to make the insulin from these beta cells inside the body that we have lost. The indigenous beta cells have been lost here. However, we need to now find a way to protect these implanted beta cells so they're not destroyed by the body's immune system, they're not rejected by it, as well as the autoimmunity in a person. So we are hoping that the future will be an iterative set of cell-based therapies with improved efficacy and safety, reduced immunosuppression, and probably someday no need for any more encapsulation. Let me give you some focus areas here. So as I mentioned in the previous slide, where we want to be in the future is we want to absolutely make sure that we have a reliable and scalable source of beta cells that can be used for anyone that's ready for cell therapy. And then we need means to protect these beta cells from being disintegrated in the body, rejected by the body, or destroyed by the immune system, by the autoimmunity in the body. So most of the focus are the areas of our research strategy will rely on trying to get over these technical hurdles and then make these therapies go into clinical development here. I'm really pleased. In the next slide, I'll give you some examples of those, but I also wanted to show a little bit of the pipeline that I showed in the first or the second slide here, how JDRF works across the pipeline. And these are 3 recent examples of really exciting data that came out over the last 30 or 60 days, 1 or 2 months here. As you go from left to right, these are different stages of research. The leftmost is earlier stage of research. What was recently found is Dr. Kistler and team at the Joslin Diabetes Center is able to take some beta cells and do some what we call gene modification, just tinker with some of the genes and provide resistance that the beta cells are no longer destroyed by the immune system. It's early stage research, but it's very promising. If we can create these beta cells now resistant to the immune system, it's a decoy tactic. Maybe this will become a source of implantation in future that will not require a protection strategy. In the middle there is again along the pipeline where we have funded a lot of basic research in the labs of Dr. Garcia and Shirwan, where they were generating what we call smart biomaterials, the sheath around the cells to protect them. These biomaterials have a self-modulating capability built inside of them that can provide protection from protection to the cells from the immune system. Through our support and our brokering, now it's in the hands of a small biotech company called iTolerance here. And so we also make sure that the research we are funding does have a pathway to product development. That's a very critical component to it. The research is important for knowledge gaining, as well as important to make sure there is a pathway to the product development that people can benefit from. To the right is actually a very different example where we worked with a small biotech company over the last 8 or 10 years. I'm sure all of you have heard about it, called ViaCyte. They have their own proprietary beta cells or stem cells that make insulin that we supported a lot. And now we're really proud that ViaCyte is in human clinical testing of 2 different products. And JDRF is directly funding one, but is also advocating so that ViaCyte can get additional support. And most recently, they have been supported by the California Institute of Regenerative Medicine that JDRF advocated for, as well as the company called Gore Inc. And so that's how I think we look at the strategy here. We do what we can with our resources, but we provide a lot of non-financial resources to make sure that, these companies and academic centers are poised for success. At the bottom chevrons there, it also shows how we work. Where we work. We work at the academic level. We work with academia and industry in partnership and collaboration. And as the case may be, we may work directly with the industry. And so it shows you that we work the pipeline and how we work across the best science that's out there to support our research and accelerate our mission. As I'm giving you a couple of examples in each case, it's always hard to pick because there are many more exciting things going on here. I just spoke about ViaCyte, so I'll skip that. That's to the left of the slide here. To the right is another basic research that we funded in the lab of Dr. Melton at Harvard University that developed these cell sources that produce insulin. Now, they look like beta cells now. That was acquired by a small biotech company called Sema Therapeutics that the JDRF T1D fund invested in. And last year, a mid-sized biotech company called Vertex acquired this particular cell sources, cells from Sema, and now they're collaborating to actually enter the first human clinical testing of these cells. And eventually they will obviously develop this product and other products down the pipeline here. So it's actually super exciting times right now. We have other clinical studies going on in the cell therapy space here. So more to come in the future. These are very challenging pieces of science, and obviously it takes a lot to develop these products, but we'll be laser focused on making sure that these cures do become available to people with diabetes soon. The next slide, we will, sorry, I'm doing the slides here. Let me now switch gears a little bit to improving lives. Now, improving lives is an area JDRF has had a lot of success in the last 10, 15 years or so, primarily in the area of artificial pancreas project, but also in some of the other areas. So today what we have available is 2 approved semi-automated or hybrid closed-loop systems in the United States, and there is 3 actually in Europe, and hopefully more in the US coming over the next 12 to 24 months and so. We have multiple really good pumps now, CGMs, we have interoperability now, so coordination between pumps and CGMs, so people have choice now. There are improved insulins coming out every day, both basal insulins as well as mealtime bolus insulins. We have glucagon options now for rescue. However, some of the other drugs that have been approved in the past, such as Simlin and Farxiga and Zynquista, they're very geographically polarized, and there's been limited adoption of these. And I'll get to that in the next slide in a minute. And we also have treatments for eye disease here. Where we want to be in the future is fully automate, get better outcomes, and remove the people component to be, reduce burden completely. We also need to reduce the on-body burden, have smaller devices. Can the consumable last longer than 3 days? Can we make that 7 days, 14 days? That will be a focus for us. We do want to support next generation transformational insulins. Why are the insulins not smart, like the body makes it? Why do the insulin not go to the liver? So on and so forth. We can't be complacent with the insulins we have today. We need to do better. And there's a huge potential for adding therapies on top of insulin called adjunctive therapies to give you not only better glucose control, but also give you a lot of other controls that provides a metabolic balance in the body that is critical to keep a person with type 1 diabetes healthy and free from complications. We will continue our focus on long-term complications, primarily in the kidney and eye area, but we do keep an eye on a systemic level for the entire body. And very critical for a chronic disease like type 1 diabetes that requires 24/7 management, the psychosocial burden and the behavioral health challenges are really insurmountable. So we have a focus in research strategy on psychosocial research, providing mental health interventions that can improve outcomes, both the mental health, improve the mental health, but actually also end up achieving hard diabetes outcomes that are better. So these are the projects we are focusing on here. To the top left are artificial pancreas automated systems here. To the bottom left are better drugs, smarter insulins, liver targeted insulins, as well as adjunctive therapies, because we know there's a lot of promise in people, both in the short term and in the long term. To the top right is our focus on complications, and on the bottom right there is the therapies for alleviating the psychosocial burden. Let me give you a couple of examples here. Now, I'm sure this crowd will recognize the 2 images on the left there. These are the 2 hybrid closed-loop systems available in the market in the US today, and a pipeline of more devices coming out in the near future. But what's exciting is people have choice now. They're being approved for lower age groups. They're obviously improving outcomes, both critical diabetes glucose outcomes, as well as reducing the burden here. We just hope that there's more choice for people, and there's also access and affordability for these here. And the SDP funding that you all advocate for continues to provide critical support. And the bottom, the device to the bottom left, the main clinical study was actually supported almost entirely by the SDP funding here. So thank you all for advocating for the SDP money there. In my final data slide here, I'll give you 2 examples, as I have been doing throughout this strategy presentation, is examples in the area of complications. To the left, and I apologize for the technical graph here, but to the left is actually number of days in hospital stay with a simple psychosocial intervention. So these are adolescents that are not able to meet their hemoglobin A1C numbers. They're very, very high, it goes through the roof there. And their therapy is not changed at all. Whatever therapy they're on, there is a psychosocial intervention that is deployed there. And this was supported by the Hempstead Charitable Trust. And now JDRF is also supporting the follow-on study in a broader scale here, including in the underserved area. So it shows, as you go from blue to green to red, the number of days in hospital stay was reduced significantly in these adolescents with type 1 diabetes and high A1C. And that's because they were adherent to their therapy. They were seeing A1C improvements without any change in their therapy, but with the psychosocial intervention given. It also had a huge cost saving. To the right is actually a lot of basic research that JDRF funded 2 decades ago that identified a potential drug for eye disease. And then we collaborated or advised 2 different pharma companies, and we have these therapies today available in the market that's actually preventing the progression of eye disease towards blindness. So that's actually pretty huge, because the prevalence of eye disease in individuals with type 1 diabetes, 20 years of type 1 diabetes is actually pretty high. So it's critical to maintain that, make sure that these end organs are safe: eye, kidney, heart, etc., etc. You have seen a lot of news. I know this is the first RIV call of this fiscal year here. So I'm just going to give you a couple of examples, but there has been more progress in the last 4 months through the summer here. So in the news is another hybrid closed loop system, but now approved as low as age 2 years. And this was a trial done in 2 to 6 year olds. That, I think, is huge progress to take the burden out of the child and the parents in the family there, to automate glucose control as well as provide better outcomes. So this will be the first of its kind that has gone down to age as low as 2 years of age. But we know that more systems are coming, including Medtronic's second system, and Tandems and several other companies are coming that are improving on their own as well as other devices, and going down in age and other populations. This was another fast-acting insulin. You all have heard about Novo Nordisk's Fiasp that was approved a couple of years ago. This is Eli Lilly's insulin called Lyumjev that was approved sometime in the middle of the summer. It was presented at the ADA. So it's exciting times that people have the choices right now, and there are better insulins coming on the market. But as I told you, JDRF always has a vision to where we need to be 5 years from now. And most of our research strategy is focused in that space. I'll end with this particular exciting presentation. There are many major diabetes meetings throughout the course of the year, and that gives us an opportunity to get a glimpse of what's coming out and new results presented. So the European Association for the Study of Diabetes, this is the largest meeting in Europe in diabetes held each year. It was obviously virtual this year, was concluded last week, and you can read the statistics. I will not repeat them there, but you see the criticality of JDRF research here. The number of studies that were presented, the number of scientists that attended the meeting. And in other years, we are all there in person interacting and holding many meetings. But obviously this year, everything was done virtually. There was also a significant amount of presentation on type 1 diabetes and COVID, which is critical right now, given the situation with the pandemic here. And there will be a blog going out with more details on it that our Marcom team has developed. So you can read it at leisure to know more details about it. And if you have any questions, let me know. So once again, I really want to thank you all for your time, your continued support, and most importantly, for being ambassadors for JDRF research. And the incredible help that you guys provide to make us successful today. So thank you very much.